Are you experiencing anterior hip pain? Typically, a lot of people will say, I've got a hip flexor strain, or I feel a pinching sensation when I'm sitting down. I'm Dr. Gouveia here with HealthFit Chiropractic in Boca Raton. Today we're going to discuss anterior hip pain. What are some of the common causes of it? Like, it can be a hip flexor strain, or maybe a pinching or an impingement syndrome, or a labral tear. We'll talk about how we evaluate these conditions, determine which one is truly causing your pain, and what are some management options for it. We'll take you through some exercises, we'll take you through some take-home stretches and tools that you can use on your own, and we'll actually provide you with a solution for it. So if you're experiencing anterior hip pain and you want to get to the true source of it, come see us at HealthFit Chiropractic and watch the rest of this video for a little bit more insight. Okay, so today we've been talking about anterior hip pain. And like I mentioned early on, there's a lot of different causes of anterior hip pain. You can have a hip flexor strain, which is what a lot of people always call it. You can have a groin strain, you can have femoral acetabular impingement or hip impingement. We're gonna dive into that a little bit more. You also have to be worried about a labral tear potentially, or a hernia. We'll rule all those different things out here in the office when you come here. And then the final thing that we're gonna rule out is it a spinal source? A lot of the times you can actually have low back pain radiate into that groin anterior hip region. And we would have already ruled that out before we even get to this stage. I think it's something like 71% of hip pain comes from the back. So this is not a rare situation. So if you come to the office and you say I have hip pain, the first thing we do is look at your back. It's not because we're chiropractors and only deal with the spine. It's because we know that a lot of hip pain is of a spinal source. So with Stefan, we've already ruled that out. So now we're gonna look into what are some other factors that play into the hip pinching or pain that he gets. So the first thing I'd have him do is just standing there and bring his hip into flexion. I just want to see if that actually causes pain. When we activate that hip flexor, does he have any issues? So go ahead and try that for me. And now if this causes pain, there's multiple reasons for it, potentially. However, one of the common ones is we're activating that hip flexor, we're pulling into hip flexion, and it can actually be uncomfortable if that muscle is truly strained. The next thing that I'd want to look at is he'd go shoulder width apart, and I'd have him go into a squat. And so in a lot of cases, this squat can be very painful. There's a ton of pieces of information we can pull out from this, but in this case, we're gonna say he actually has pain when he goes into the deeper part of the squat. So he's good. And then all of a sudden we get past 90 and he has full hip flexion, and that's where he's feeling the pain. So that can be a sign of that hip impingement, or something is kind of pinching in the front of that hip. And we definitely wanna rule that out as what could be causing that. So Stefan, I'll have you go ahead and sit here on the table. You're gonna lay on your back. And so come on in, we're gonna talk about what can be causing this. So the first thing, let's say that first test, that hip flexion caused pain. Well, it should also cause pain when he's laying on his back. So I'm gonna have him go and he's gonna do a resisted hip flexion. This is a true kind of isolation of those hip flexor muscles, the psoas, the rectus femoris, and how that kind of plays a role. That would feel pain if it's a true hip flexor strain. Now, what we're looking at next is a potential impingement. We call it femoral acetabular impingement. And what that is right here at the front of the hip, you'll find that it actually can pinch the tissue. So if we go into hip flexion like this, and that causes him pain when I'm moving it, those muscles are not turned on. That's not a hip flexor strain. So even when people come in and they say, I've strained my psoas, I've strained my hip flexor, if you feel pain when that muscle is completely turned off and I'm doing all the work for you, it's likely something else. And so with femoral acetabular impingement, there can be a lot of things at play. There can be structural deformities. I'm not gonna get into too much detail, but you can have bony deformities. They're very common that actually cause a pinching of the tissue in the front. But it can also just be a biomechanical issue. And so in this case, what I wanna see is, can we change the pain that he feels? So before we even get to those changing factors, we'll go through a few tests. So there's one called Feder's, which is flexion, adduction, and then internal rotation. This is very, very painful in people that have a true hip impingement. And then we have flexion Feder's, flexion, abduction, and external rotation. This should be not painful in somebody who has a hip impingement. And so this is a good tool to see if when we close down and approximate that joint like this and it hurts, there's likely something else going on. So what we want to see is how can we affect that pain? So the first thing I'm going to have Stefan do is, before I go up into hip flexion, I'm going to ask him to try and push his belly button down to the table, round his back out. If he feels relief with this, then it may actually have something to do with his pelvic positioning, because If we arch our pelvis forward and then we come up, we actually close down the gap in the hip and we can pinch the tissue, and that can cause a lot of that pain. Versus when I ask him to round the back and we bring our hip up, we'll actually find that we open up the space and there's less of a pinching sensation there. And so if that's the case, we're gonna work a lot of core, a lot of pelvic mobility and motor control so that he can use that when he's going into a squat, when he's in a seated position, so he doesn't have that same pinching sensation. The next thing that I would do is I would actually say, okay, Stefan, I want you to push your belly into my finger here. Just push on it, push on it, push on it. Good. And then we go into the same flexion. To the patient, this may seem really weird. Maybe it's like, why are you asking me to push my belly out? What we're doing is we're causing intra-abdominal pressure. We're causing core activation. If you feel relief with this, then we know, okay, the core isn't stabilizing well. And so when we go into flexion without core activation, you're causing that pinch again because of the lack of control. The core controls the pelvis and controls your rib cage. And believe it or not, those are heavily influencing on that hip. So when we do get into treatment, whichever positions or different tweaks that we use that offer relief, we're gonna implement that into our rehab. We're gonna teach pelvic tilting in order to open up that hip. We're gonna mobilize that hip because you potentially may have that pinching sensation from just a bunch of muscles that are overactive, pulling that joint tight and basically decreasing the space for the joint to move. So how do we address that? Well, the first thing that we do is we're gonna do manual therapy. We're gonna do active release technique. So we'll do a hip flexor release where we pin it down, we lengthen that muscle and bring it down. We'll do multiple passes like that. We may also work on the groin muscles, which heavily influence the position. So we'll come up, we'll pin that muscle, we'll come all the way out. We may lengthen it just like that. Good. I'll have Stefan flip on his side, face that way. Some other muscles that can be involved are some of the lateral hip. All of these muscles play a role in the centration of the joint. So if some are tight on one side and some are weak on the other side, that hip joint won't actually sit square in that socket. It's a ball and socket joint. So this is a really important factor. If you think of this as the actual hip joint and this is the femur or the hip, if it doesn't sit right in the middle and it's higher up one way or on the other side, you'll have more of a pinch. So if we release the muscles that are pulling it up and it can centrate, sit dead center in the middle, you have way more space for that joint to move. And so that's really important. That's why we use ART and we use all these treatment techniques. Go ahead, flip on your back again. Some of the other things that we'll use is joint mobilization. So I'll have Stefan bring his leg right up, bring the side of our hand right kind of in the crease, and we'll pull that hip down, tractioning it, and then we'll move into flexion. And this should not be painful anymore if you're experiencing a hip pinch because we're opening up that joint and allowing it to glide. And so this can be really useful for these hip pinching and sensation positions to mobilize that joint. We may also do a long axis traction where he lays on his back, hold the table for me, and we'll just pull and we'll do a little traction just right along the axis there. Sometimes we'll do an impulse, but a lot of the times I'll just do a joint mobilization where I feel it and at whichever angle it feels the most restriction. This can help actually allow the joint to clear up, open up once we've released those muscles and start to influence it. So once we've got that joint moving well here in the office, in the manual treatment room, we then go out to the rehab area and we load it. And then we create resiliency for it and make sure that this pain doesn't come back the moment he returns to sport, returns to sitting, or whatever his aggravating factor is. So when you're dealing with that anterior hip pain, whether it's a psoas strain, like we talked about what that would look like, or an impingement, this is a really good stretch for it and something that I like to prescribe most of my patients. Now, if it's a strain, I want you to be really careful. This should be a pain-free stretch. It should not be really eliciting it. It's okay if it feels like, pulling. Naturally, we're gonna be stretching that tissue, but I don't want it to be painful. If you're dealing with FAI, femoral acetabular impingement, or that pinching sensation that we talked about earlier in the video, this is also great as an anterior hip opener. So what Stefan's gonna do, he's gonna go into a half kneeling position there for me. I want him to drive his hips forward. The back stays really neutral. A lot of common mistakes I see is they arch. I don't want an arch in his back right now. I want him to feel like he's pushing the hips directly forward. He'll go up, throw his hands up like that. He's gonna hold that for 10 seconds. After 10 seconds, he's gonna lean away. We're gonna get a little more stretch on that psoas. We're gonna feel some lat stretching, just working through all of that anterior and lateral hip, and that's a really beneficial one. 10 seconds pushed forward, 10 seconds leaned away, and if you do that a couple times a day, you'll really start to open up that hip, which is really beneficial for both those conditions that we did talk about. So now we've talked about a stretch that you can use to open up that hip. I don't know if you remember, but earlier in the video, I talked a lot about hip centration, and a little quick recap is if this is your hip joint, this is the bone. We want that bone to be right in the middle. We don't want it riding up, we don't want it riding down. And so when we're moving that hip, we want it to be in the middle and we want to have control of it. And so in order to do that, what we want to train is what we called a controlled articular rotation, meaning we're going to go through a full range of motion in the hip, basically gliding that hip joint through all the different ranges that that socket has. But we don't want to pinch, we don't want to feel any, any pain with this, but we do want to work through it really slowly. Whenever I'm explaining this to a patient, I like to picture you're grinding through the entire concavity of that joint. You're sliding through all the extreme ranges of motion that we don't get into in a day-to-day. So Stefan will go ahead and go in the quadruped position or all fours. I'm going to come over to the other side here. What he's going to do is I'm going to actually have you start going into extension. So the leg's going to come back. This is the first position, making sure that his back doesn't arch and that it's true hip extension. Then he's going to come out with the leg and moving forward, and he's just trying to go as far as he can. Bring that knee all the way up to your chest, Stefan, so go ahead and do that again. Yep. We want to be careful. That's where we might feel a pinch with the femoral acetabular impingement, that hip impingement, and we want to be careful that we don't feel any of that pain. If he does, remember that we said that in his case specifically, we found that pelvic positioning influenced it. So go into flexion again with your leg. Want to make sure that his back is rounded and not arching, because if it arches, go ahead and try, that will pinch it more. And so we play with this when we're here in office to tweak it so that it's suited best for the patient and what we saw on our exam. So go ahead and do a couple reps here, and I'm going to point out a few different things. So we don't want too much arch. We want it to all be hip flexion. He's going to come all the way up. We want to be careful about his pelvic tilting. So Stefan, come out to the side again for me. If he tilts too far like this, it's no longer hip motion. We want to keep that core tight and that body and trunk neutral, and he might not be able to go very far. You might feel like you should have your leg up like a dog at a fire hydrant, but really we want to only go as far as we can, and each repetition will get better. Keep going through it, and that's really good. That's true hip mobility here, going into flexion, making sure it's not pinching, and if it is pinching, just come off of it a little bit. Don't go quite as deep into that stretch or play with the back position based on what we advise you to do. Doing 5 to 10 of these on each side, a couple sets a day is really beneficial. It is shockingly tiring. It seems easy to go through that mobilization. It's like, oh, I'm just moving my hip. No, the moment you start to get into these, you'll fatigue quicker than you expect. And so I say 5 to 10 because you may be fully fatigued at 5 reps. And with this, it's really important that you don't lose form. I would rather you do 5 really good reps than 10 reps that things fall apart and that your core's not activated and that we're not in proper positioning. It's defeating the purpose at that point. So think about that, pelvic tilting, back being neutral, core being activated, staying out of pain, but working through that entire range of motion. If you recall when we were doing treatment in the treatment room, I did a little distraction. I pulled down on the hip, I pulled it out, we went into deep flexion, and it actually relieved his pain. It allowed him to go into full hip flexion without having that pinching sensation. Well, you can achieve this here on your own, whether it's at a gym or at home, depending on the bands that you might have. And what this band will do is we have it set up so that it sits really deep in there. It should go right in the groin, right in that crease. And what that's going to do is it's going to distract that hip bone down out of the joint just enough. We're not dislocating it. We're moving it a very small amount, but sometimes that's all that's required to actually get that range of motion back. When we have that hip distracted, now we're going to mobilize it. We're going to mobilize it through 3 different planes. First, we're going to go in like this. Good. Back and forth 5 times. And this should be pain-free now. The goal of this is to provide a mobilization that does not hurt, even if you have that pinching sensation. Good. After a couple reps of that, he's going to go outwards. Same thing again. 5 reps. Good. 2 more. Good, and then he's going to drive his hips forward, and we're going to go into more of a stretch like that, pulling that hip backwards. And these are really good mobilization drills that you can do. They, again, Can't stress enough that they should be pain-free, your back should be neutral, no arching. And what this will do is it'll actually open up some more space in that hip, allow you to mobilize it. Then what I have my patients do is I have them go through some strengthening stuff for those muscles that support the joint. Now that the joint moves better, we reinforce it with strength so that way the changes that we make, they're not just temporary changes, we load them and we create a long-lasting effect that can get them out of pain, but also keep them out of pain, because that's our ultimate goal here. If you're experiencing anterior hip pain, now that we've shown you the evaluation that we'll take you through, some potential treatment options for your condition, and some take-home options, if you continue to have this problem after trying some of our take-home exercises, give us a call at 561-997-8898. We'll have one of our doctors at Chiropractic here take you through a full evaluation to determine truly what is the cause of your symptoms. And this will put you on the road to recovery and get you out of that pain and back to the sport that you love.